Welcome to the module Psychiatry. I am Dr. Jenny Kale, and I'm an emergency medicine clinical specialist at Massachusetts General Hospital here in Boston, Massachusetts. This presentation is part of the ACCP and ASHP Emergency Medicine Pharmacy Specialty Review course, which is designed for pharmacists seeking to update their knowledge and skills in preparation for board certification. The activity is designed to be interactive, and questions will be posed to you at several points. I will pause to allow you time to consider how you would answer the question. You may wish to write down your answer and the correct response in your handbook. I do not have any financial relationships to disclose. The learning objectives for this module are to interpret signs, symptoms, laboratory, and other diagnostic and acuity results, develop therapeutic monitoring plans based on medication-related problems, patient and disease-specific information, and laboratory data, select alternative routes of administration based upon patient-specific factors, modify treatment plans based upon monitoring patients' response to initial therapy, and assess applicability and limitations of published data and reports to patient care. Now, starting with our patient, who is a middle-aged male and found unconscious on the sidewalk by a police officer. The patient had snoring respirations and a respiratory rate of 6 breaths per minute. He was unresponsive to sound and tactile stimulus. On palpation, he had peripheral pulses but was cool to the touch and had a Glasgow Coma Scale score of 6. A syringe was found on the sidewalk next to the patient. As opioid abuse has increased in the community, recognizing an overdose and quickly administering naloxone in the pre-hospital setting may result in patients being revived with minimal neurologic impact. Thus, as a life-saving measure, naloxone administration intranasally or intramuscularly has been added to the ACLS algorithm in the event that overdose is suspected following initiation of chest compressions. So recognizing the signs of an opioid overdose is critical. As a central nervous system and respiratory depressant, an overdose of an opioid, depending on the severity, a patient may exhibit slow or absent breathing, cold or clammy skin, small pupils. They may have gurgling or snoring sounds or be difficult to arouse. Opioids are potent agonists of the mu, kappa, and delta opioid receptors throughout the body. Specifically, agonism of the mu opioid receptor results in the desirable feelings of analgesia and euphoria, along with the undesirable effects of sedation, respiratory depression, GI dysmotility, and eventually dependence, due to changes in the brain's chemistry and activation of the pleasure pathway. In time, with decreased respiratory effort, patients become hypoxic and hypercarbic, which further worsens their altered mental status and respiratory drive. Naloxone is a potent opioid receptor antagonist in the brain, spinal cord, and GI tract, and rapidly reverses central nervous system and respiratory depression caused by opioid overdose. Naloxone is indicated in any person who is unresponsive or at a potentially dangerously low level of responsiveness and thought to be or known to be due to an opioid. It is important to note, in the event of a polysubstance overdose, naloxone will not reverse the toxic effects of other substances such as alcohol, benzodiazepines, amphetamines, or cocaine. When administering naloxone, due to the nature of its opioid reversal, precipitated withdrawal may occur. Now, we'll discuss different dosing mechanisms in a few slides that may be considered if trying to avoid full reversal. Naloxone has a therapeutic duration of about 90 to 180 minutes, so repeat dosing may be needed if moderate to long-acting opioids were ingested, necessitating frequent patient monitoring. And as stated previously, as the frequency of opioid overdoses continues to increase in the outpatient setting, the CDC now recommends providing naloxone to anyone at risk of overdose. This recommendation is particularly pertinent to us in the emergency department, as we are able to provide naloxone prior to patient discharge back into the community. Now, typically what to give in an overdose setting is not the question. Rather, the more common and less straightforward question is, how much naloxone should I give? In terms of what dose to give, we walk the line between giving just enough to increase the respiratory rate, but not too much to precipitate iatrogenic withdrawal that makes your patient uncomfortable and oftentimes quite upset. In addition to this balancing act, the correct answer may also be dependent on the setting in which the overdose has occurred. A recent study in Massachusetts found that about 80% of individuals who survived an opioid overdose in the outpatient setting with the use of nasal Narcan needed 2 or more intranasal administrations of 2 milligrams per dose to obtain a response. So when in the community, I recommend 4 milligrams intranasal off the bat. However, if you only have the 2 milligram intranasal product, I would have a low threshold to give a second 2 milligrams in the alternate nostril, which yes, may tip you toward the withdrawal side of the scale, but better to overshoot and save a life when not in a medical setting. If no IV is established, intramuscular administration is also a preferred route, but keep in mind it will have a slower onset of action, but it will also have a longer duration of action. If your patient is less somnolent but is in need of arousal, you can dilute the dose of naloxone and give smaller aliquots until the desired effect is obtained. This method may also be used if you do not want to fully reverse the opioid, as the case if the patient is chronically on opioids, or if continued pain control is needed, whereby making full reversal undesirable. To do this, your 1 milliliter of 0.4 milligrams naloxone is diluted in 9 milliliters of normal saline, and then you give 1 to 2 mLs or 0.04 to 0.08 milligrams naloxone at a time. And if the patient took a longer acting opioid like methadone, a continuous naloxone infusion or nebulization may better match the duration of action. This table lists the various routes of administration, recommended starting doses, time of onset, and a few helpful tips. If the patient is exhibiting clear signs of opioid overdose, or the overdose was witnessed, and he or she is not responding to initial naloxone doses, don't be afraid to quickly escalate the dose to avoid intubation or further patient harm. Reported maximums in the literature are in the range of 12 to 15 milligrams intravenous. Now, we've already discussed the intranasal route as well as titration via the IV route. I do want to highlight that the intravenous route has the fastest onset, and if a continuous infusion is needed, we typically start the infusion at 2/3 of the wake-up dose per hour. So for example, if it took 1 milligram of intravenous naloxone to obtain the desired response, we would start the infusion at 0.6 milligrams per hour. Nebulized naloxone has become more popular recently in some institutions, as it is somewhat self-titrating and easy to make at bedside by adding 2 to 4 milligrams of naloxone to 3 milliliters of normal saline in a nebulizer cup. The only problem is that the patient does need to be taking adequate breaths in order for the drug to take effect. Routes that I did not list on the slide, but did want to mention, are via the endotracheal tube and intraosseous route. These routes are used less frequently in the recent years with increased intranasal naloxone availability, but they are available if needed. Whichever method of administration you are using, just remember that naloxone has a shorter duration of action than most narcotics, so vigilance and repeated doses are often needed while the opioid effect wears off. Back to our patient case. Remember, this is a middle-aged male who was found unconscious on the sidewalk by a police officer. The patient had snoring respirations and a respiratory rate of 6 breaths per minute. He was unresponsive to sound and tactile stimulus. On palpation, he had peripheral pulses and was cooled to the touch and had a Glasgow Coma score of 6. And then a syringe was found next to the patient on the sidewalk. Now this brings us to our first assessment question. Our patient has overdosed on an opioid and is suffering from respiratory depression. Which of the following represents the most appropriate naloxone dose and route of administration? Is it A, 2 milligrams intravenous, B, 4 milligrams intranasal, C, 0.04 milligrams intravenous, or D, 0.04 milligrams intramuscular? The correct answer is B. The patient does not have intravenous access as he was found on the sidewalk, and the quickest way to administer the naloxone is either intranasally or intramuscularly. The intramuscular dose listed on the slide, 0.04 milligrams, is too low of a dose for a patient in respiratory distress and unresponsive. Therefore, B is the correct answer. We will now move into our second segment discussing the management of acute agitation. I want to specify that in this section, when I am discussing acute agitation, I'm referring to the emergent situations that break the therapeutic alliance and may place the patient or staff in danger, requiring immediate pharmacologic intervention. Treatment of overtly agitated, violent, or psychotic patients in the emergency department is not infrequent, but continues to be one of the most clinically challenging presentations, as we often lack information about patients' past medical history and psychiatric history. Additionally, there is a lack of high-quality data and recommendations guiding therapy, and so what I will discuss today is largely based on expert consensus. Although difficult in many clinical scenarios, managing agitation relies on identifying and treating the underlying cause, even if only a provisional diagnosis. The most common cause of acute agitation are listed on this slide and include intoxication with alcohol or other substances, a primary psychiatric illness including schizophrenia, bipolar disorder, personality disorders, anxiety or panic disorders. It could be medication-induced, potentially from polypharmacy, as well as from a medical condition such as infection, hypoglycemia, or hypoxia. Delirium and pain may also lead to agitation if not appropriately treated. Now, I do want to take a second to highlight pain, as some patients, particularly geriatric patients, are often not able to appropriately communicate pain. So a full assessment of painful conditions should be performed and treated with analgesics, not sedatives, as appropriate. There are many organizations that provide support and guidance for the treatment of acute agitation in the emergency department, and although there is not full consensus on which drugs are optimal for pharmacologic calming, there are a few guiding principles that are agreed upon throughout the medical community. The first and likely most important is to only utilize medications when necessary to ensure patient and staff safety. The therapeutic goal of treatment is to calm and not sedate the patient. Oversedation can lead to unnecessary escalation of care and length of hospital stay. Although challenging, an attempt to uncover the underlying cause should be made to guide thoughtful medication selection. Oral medications should be given, if able, based on the patient's level of cooperation. And allowing time for therapeutic effect is often the hardest principle to follow due to the high stress of the situation. However, redosing too soon or adding additional medications prematurely can result in increased side effects and unwanted sedation. So please try to stay calm and utilize non-pharmacologic approaches during the excruciating waiting period. I have found that good communication with team members about time to onset really does help with appropriate medication use and expectation setting. And finally, avoiding administration of agents with similar side effect profiles is recommended to not compound the effects. The assessment and treatment of an agitated patient is complicated, and the cooperativeness and/or inability to give a relevant history often forces clinicians to make treatment decisions based on very limited information. So, in the undifferentiated patient, the optimal medication is one that is easy to administer, provides rapid calming without oversedation, and with minimal risk of adverse events. Now, there is no medication, as I've said before, that is considered to be best. However, pharmacologic management of acute agitation has traditionally employed three classes of medications, including first-generation antipsychotics, second-generation antipsychotics, and benzodiazepines. Although these medications can be given for management of most agitation presentations, careful attention should be made to older adults, as first and second-generation antipsychotics are specifically not approved by the FDA for dementia-related psychosis due to increased risk of cerebrovascular adverse events. First-generation antipsychotics have a long history of use for the treatment of agitation. These medications inhibit the transmission of dopamine in the brain, which reduces the psychotic features inciting the agitation. The two most common first-generation antipsychotic agents used in the treatment of agitation are haloperidol and droperidol, which are both high-potency dopamine 2 receptor antagonists. Of note, the use to treat agitation with droperidol is currently not approved by the FDA. Because these medications block dopamine transmission, they should be avoided in patients with Parkinson's disease or Lewy body dementia, as they can worsen the movement disorders. Additionally, if the agitation or delirious state is due to an anticholinergic toxicity, antipsychotics especially first-generation antipsychotics, should be avoided due to additive anticholinergic effects. Haloperidol is available in 3 routes of administration, including oral, intramuscular, or intravenous. The FDA has not approved the intravenous route for treatment of agitation due to the risk of QTC prolongation. However, many institutions do utilize this route when the benefit outweighs the risk. Haloperidol has been associated with increased frequency of extrapyramidal side effects when compared with second-generation antipsychotics. However, the exact incidence of dystonic reactions following administration is difficult to ascertain, as movement disorders are poorly characterized. Many institutions will administer an adjunct medication such as promethazine, diphenhydramine, or benztropine to prevent undesirable extrapyramidal symptoms. However, this has been associated with higher levels of sedation and longer lengths of ED stay. Droperidol was widely used for behavioral disturbances until the FDA placed a black box warning on the medication for QT prolongation. However, subsequent studies have demonstrated that the risk of QT prolongation from droperidol is low, with a safety profile similar to benzodiazepines and higher efficacy in calming the agitated patient. Institutions across the country are beginning to re-add droperidol to their formularies, as large studies published in the recent years have supported its acceptable safety profile and efficacy as an analgesic, sedative, and antiemetic agent. With that said, I would recommend to make an effort to obtain an ECG prior to administration if able. Overall, all antipsychotics prolong the QTC interval, and caution should be taken in patients with channelopathies, congenital or baseline prolonged QT, and use with other QTC prolonging medications. However, risk of QTC prolongation should not preclude use in the acute setting. Second-generation antipsychotic agents are now the drugs of choice for treating agitation stemming from an underlying psychiatric illness, as they have a more favorable side effect profile and similar efficacy compared to the first-generation antipsychotics. Olanzapine and ziprasidone exhibit different receptor binding, with olanzapine being a dopamine 2 receptor antagonist, serotonin 5-HT2A receptor antagonist, and an antagonist at muscarinic and histamine receptors. In comparison, ziprasidone has higher serotonin antagonism. These differences lead to variances in their side effect profiles, with olanzapine having higher rates of orthostatic hypotension, particularly in the geriatric population, and ziprasidone associated with greater QTC prolongation. Now, risperidone also has action on multiple receptors, including dopamine, serotonin, alpha-2, and histamine, and therefore also carries the risk of orthostatic hypotension. Interestingly, there's also been an association with increased risk of stroke in elderly patients with a history of cardiovascular disease who are taking risperidone. Olanzapine and ziprasidone are the second-generation antipsychotics most commonly used due to their availability in multiple dosage forms. Of note, olanzapine is available in an oral disintegrating tablet and as a solution that can be given intramuscularly or intravenously. However, like haloperidol, the intravenous route is not FDA approved. Something to highlight is the recommendation to avoid concomitant administration of intramuscular olanzapine and intravenous benzodiazepines due to the risk of orthostatic hypotension and cardiorespiratory depression. The current recommendation is to separate administration of the two agents by at least 2 hours. I will say there are ongoing studies looking at if this risk may be overstated. QTC prolongation is the primary concern following second-generation antipsychotic administration, as olanzapine, ziprasidone, and risperidone have all shown to prolong the QTC interval. When compared, olanzapine exhibited the least QTC prolongation. Benzodiazepines may be preferred to treat the undifferentiated, acutely agitated patient with no prior history, or when broad central nervous system depressant effects are desirable. When administering benzodiazepines, a conservative dosing strategy may be best, as response is often unpredictable due to tolerance and dose stacking, or combining with other CNS depressants, which should be avoided. Lorazepam and midazolam are the preferred benzodiazepines due to their rapid onset and short half-life. Midazolam features a highly lipophilic profile with more rapid onset and offset, whereas lorazepam has slower onset and longer-lasting sedative effects. The rapid onset and short half-life allow for more rapid de-escalation. Midazolam and lorazepam are also preferred due to their ability to be administered intramuscularly with predictable absorption, which is often necessary when unable to place an IV or administer oral medication. You will notice in the table that intramuscular administration of benzodiazepines does have a slower onset when compared to the IV route for both lorazepam and midazolam. The side effects of both agents are dizziness, oversedation, paradoxical reactions, and respiratory depression when used with other CNS depressants like alcohol. So, in your acutely agitated patient due to alcohol intoxication, benzodiazepines are suboptimal. Ketamine is an attractive option as it results in rapid and predictable calming, or as many studies call it, tranquilization. Additionally, ketamine can be administered via the intramuscular and intravenous routes. To control agitation, dissociative doses of ketamine are necessary, being 2 to 5 milligrams per kilogram intramuscular or 0.5 to 1 milligram per kilogram intravenous. Although ketamine is touted to have protective airway properties, several retrospective reviews have found an elevated intubation rate of about 20 to 60%, but this may be dose dependent. As a result, dosing at the more conservative end of the dosing range with repeat if necessary is what I recommend. Another consideration is that ketamine should be avoided in patients with chronic schizophrenia and/or primary psychosis, as ketamine's emergence phenomena may be exacerbated in this population. This table provides the basic treatment recommendations based on potential cause of agitation. As I previously stated, benzodiazepines are preferred to treat the undifferentiated, acutely agitated patient with no prior history. When an underlying psychiatric disorder is present, then an antipsychotic agent should be used, with preference for the second-generation antipsychotics. If the antipsychotic agent alone is not effective, adding a benzodiazepine is warranted. However, monotherapy with a benzodiazepine will only sedate the patient and not treat the underlying cause. Again, I will note that ketamine should be avoided in this population due to the emergence reaction. For intoxication with most recreational drugs, especially stimulants, or in patients experiencing alcohol withdrawal, benzodiazepines are generally considered first line. Chronic amphetamine users may develop psychotic symptoms from their amphetamine use, potentially requiring the addition of an antipsychotic. If immediate pharmacologic control of agitation is needed in a patient with delirium that is not due to alcohol or benzodiazepine withdrawal, second-generation antipsychotics are the preferred agents. Benzodiazepines should generally be avoided because they can exacerbate delirium. The treatment of delirium and dementia is more difficult in the geriatric population, and I could talk for hours about the treatment of agitation and excited delirium in older adults, as management is further complicated by the inclusion of multiple medications in the Beers criteria and the fact that there are currently no pharmacologic interventions approved by the FDA to treat agitation in the elderly. I will put a shameless plug that if you want to learn more about the treatment of agitation in the elderly, I recently published an article in JSUP with a few colleagues entitled "The Agitated Older Adult in the Emergency Department, a narrative review of common causes and management strategies." Now back to our patient case. The police officer administered an initial dose of 4 milligrams intranasal naloxone with minimal effect. After 3 minutes, a second dose of 4 milligrams intranasal naloxone was administered. Several minutes later, the male abruptly became responsive and agitated, yelling at the police officer. Upon ED arrival, the patient was increasingly restless, irritable, and confrontational. He was uncooperative with medical care and becoming physically violent with the staff. The police officer did not administer any medication other than the naloxone. Question 2. In an effort to calm the patient and proceed with medical assessment, the team asks you what you recommend to treat this patient's agitation quickly as his violence is escalating. Would you recommend A, 5 milligrams intramuscular droperidol, B, 2 milligrams intramuscular lorazepam, C, 200 milligrams intramuscular ketamine, or D, 10 milligrams intramuscular olanzapine? The correct answer is C, 200 milligrams intramuscular ketamine. This patient is acutely agitated and being physically aggressive with the medical team, and his anger is escalating. For this reason, the agent with the fastest onset should be administered. Intramuscular ketamine has an onset of 3 to 5 minutes, which is faster than the other agents that have onsets of about 15 minutes when given intramuscularly. Additionally, studies have found that when given ketamine, patients more often do not require a second agent, which is optimal in this scenario. Moving on to segment 3, management of opioid withdrawal. Symptoms of opioid withdrawal are due to increased autonomic hypersensitivity and include restlessness, anxiety, tachycardia, and GI upset, to just name a few. Time to onset of opioid withdrawal is dependent on what opioid was ingested, mode of ingestion, as well as other patient-specific factors. But once opioid withdrawal sets in, treatment should commence. There are currently 3 FDA-approved medications for opioid use disorder: methadone, buprenorphine, and naltrexone. Of those, we will only discuss methadone and buprenorphine as they do not require a prolonged period of sobriety prior to initiating, like long-acting naltrexone, and can therefore be initiated in the emergency department. Studies have shown that buprenorphine and methadone improve engagement in care, reduce opioid use, and decrease mortality. Logistically speaking, buprenorphine offers greater flexibility of treatment as it can be dispensed from a pharmacy at longer frequencies and does not carry the same adverse effects as methadone, being a partial opioid agonist. Our goal in the emergency department is to acutely treat the opioid withdrawal, stabilize the patient, and connect the patient to an outpatient treatment program for continued care and behavioral therapy. Methadone is a synthetic full mu opioid receptor agonist. It is available as a tablet, oral solution, and injection. Methadone has a large volume of distribution and is highly protein bound with a peak effect of 2 to 4 hours and prolonged half-life with repeat dosing. Due to its long half-life, methadone may be more difficult to dose and titrate during the induction and maintenance phases. However, the long half-life is beneficial in that it allows for once daily dosing, and patients will not typically develop withdrawal symptoms within a day or 2 of missing a dose. Another noteworthy advantage of methadone is that as a full mu receptor agonist, it will not precipitate withdrawal, so you can initiate methadone treatment even if the patient is not in acute opioid withdrawal. Initial doses of methadone range from 10 to 30 milligrams daily, with up-titration every 3 to 5 days, and a typical maintenance dose ranging from 60 to 100 milligrams per day. As a full mu opioid receptor agonist, methadone does possess opioid-related adverse effects, including constipation and respiratory depression. Methadone may also prolong the QTC interval via delayed ventricular repolarization. Buprenorphine is a semisynthetic partial opioid receptor agonist, and so it will produce clinical effects similar to a full agonist, but with a maximal opioid effect. This ceiling effect provides a wider safety margin. Buprenorphine is available as a tablet, injection, or implantable rod, as well as in a combination with buprenorphine and naloxone, which is available as a tablet or sublingual film. The combination product is preferred in the outpatient setting due to lower risk of misuse. Buprenorphine has high affinity to the mu opioid receptor and is approximately 25 to 40 times more potent than morphine, so it does displace other opioids from the receptors and therefore may precipitate withdrawal symptoms during induction. Therefore, current guidelines recommend leaving a sufficient period of time since the last drug use until clear and objective withdrawal symptoms are present before administering the buprenorphine. This is known as the traditional method of induction, and once in withdrawal, a buprenorphine dose of 2 to 4 milligrams is given with repeat dosing based on further symptoms of withdrawal, with a maximum of 8 to 16 milligrams on day 1. However, many patients cannot wait until they are in active withdrawal to begin taking the medication, as this can be upwards of 24 to 48 hours with intermediate and long-acting opioids. To address this, some are adopting a microdosing approach called the Bernese method. Microdosing involves prescribing buprenorphine naloxone in a small initial dose with incremental increases to both the dose and frequency over time. At the same time, the patient continues to use opioids, either prescribed or illicit, until a therapeutic dose of buprenorphine has been achieved. The thought is that repetitive administration of very small buprenorphine doses with sufficiently long dosing intervals should not precipitate opioid withdrawal, And because of the long receptor binding time, buprenorphine will accumulate at the receptors and slowly replace the full opioid agonist. This slide is just a quick side-by-side pro and con for your reference, all of the points I have previously discussed. You may also attenuate withdrawal symptoms in the acute phase with a combination of non-opioid targeted therapies. These therapies include alpha-2 agonists, beta blockers, antidiarrheals, and antiemetics. But you must keep in mind that although these agents temporarily lessen patient distress during the initial phases of withdrawal, they do not lessen opioid cravings. Back to our patient. Now that he is more calm after his intramuscular ketamine, he is able to provide more of his history. He's a 42-year-old undomiciled Army veteran. He has hypertension, bipolar disorder, and PTSD. He uses an array of substances but has previously been stabilized on Suboxone with sustained recovery. When asked about his alcohol intake, he states that he drinks 4 to 5 whiskey drinks per day, with his last drink being about 8 hours ago. He is not currently on any medications and has no medication allergies. Upon examination, his pupils are 4 to 5 millimeters bilaterally. He looks very uncomfortable. He's sweating with a mild tremor in both hands and states he's very nauseous. During your physical exam, you notice that he has track marks on both arms with a small abscess near the elbow crease on the right arm. He is febrile at 39 degrees Celsius, which equates to 102.2 degrees Fahrenheit. He's hypertensive, which he states is his baseline, tachycardic, and when viewing the ECG, you see that he has a prolonged QTc of 528 milliseconds, and he has a respiratory rate of 22 breaths per minute. All right, question 3. The provider is concerned about precipitated opioid withdrawal from the naloxone that was given by the police officer and asks for your opinion on management. What initial oral therapy would you recommend? A, propranolol 10 milligrams, B, buprenorphine 4 milligrams, C, methadone 30 milligrams, or D, the combination product buprenorphine naloxone, and give 2 of the 8 milligram, 2 milligram films for a total of 16 milligrams of buprenorphine and 4 milligrams of naloxone. The correct answer is B, buprenorphine 4 milligrams. The patient is in opioid withdrawal as he is tachycardic, he's sweating and nauseous. Therefore, it is appropriate to provide an opioid receptor agonist medication instead of the propranolol, which will likely only help with the tachycardia. Buprenorphine should be selected over methadone as the patient has responded well to the buprenorphine naloxone combination in the past with sustained recovery, as well as the fact that his QTc on presentation was 528 milliseconds, which may be further prolonged with methadone administration. Since the patient is in the hospital setting, there is no need for the naloxone component, and the 4 milligrams of buprenorphine is more appropriate than 16 milligrams, as this is initiation and the patient may still have opioid in his system. Moving on to question 4. 1 hour later, the patient remains tachycardic and diaphoretic and states he still feels like he's in opioid withdrawal. What would you advise the team to give orally now? A, propranolol 10 milligrams, B, buprenorphine 4 milligrams, C, methadone 30 milligrams, or D, again, the combination product buprenorphine naloxone with 16 milligrams of buprenorphine and 4 milligrams of naloxone. The correct answer is B, administer another dose of buprenorphine 4 milligrams. If the patient still feels like he is in opioid withdrawal, it is appropriate to redose the medication. Again, answer choice A, propranolol, will only help reduce the sympathetic outflow. In C, buprenorphine should be selected over methadone, as again, the patient has responded to buprenorphine in the past with sustained recovery and did present with a prolonged QTc. Since the patient is in the hospital, there's no need for the combination buprenorphine naloxone product. in the 4 milligrams of buprenorphine is more appropriate than the 16 milligrams, as the recommendation for induction is to provide 2 to 4 milligrams of buprenorphine at a time, with a maximum of 16 milligrams in the first 24 hours. And so if you selected answer choice D, the patient would already exceed that first 24-hour limit. Our next segment is discussing the treatment of cellulitis. I want to preface this section by stating that in clinical practice, your antibiotic selection should be based on local antibiograms and resistance patterns, as well as any patient-specific culture data you may have. The treatments I will discuss are based on national data and broad recommendations of the most likely organism and historically effective therapies. We considered not including treatment recommendations for cellulitis in this course. However, as skin and soft tissue infections are among the most common infections encountered in the ED, I felt it would be amiss to not touch upon the basics. The Infectious Diseases Society of America, or IDSA, recommends a simple diagnostic step that many clinicians use to determine causative agents, and that is, quote unquote, to look for pus. Once the infection is visualized, the pathogen may be identified, as non-purulent skin and soft tissue infections are likely caused by a streptococci species, and purulent infections are likely caused by a staphylococcus species, potentially methicillin resistant. The majority of community onset and non-purulent skin and soft tissue infections are caused by either Staphylococcus aureus or one of the beta hemolytic streptococcal species. So, beta-lactam antibiotics such as cephalexin, cefadroxil, or decloxacillin can be used if only a mild infection not requiring intravenous therapy is present. If the infection is more severe, or if the patient is experiencing systemic signs of infection, then intravenous antibiotics should be used, including cefazolin or ceftriaxone. If the patient has a penicillin allergy, clindamycin can be substituted. If the infection is purulent, with a concern for methicillin-resistant Staph aureus, in mild cases, oral trimethoprim sulfamethoxazole or doxycycline can be used. Clindamycin is reserved for those unable to take either of these two agents due to increased rates of MRSA resistance and side effects with clindamycin. If the patient has systemic signs of infection or an extensive skin infection, then intravenous agents such as vancomycin, daptomycin, or linezolid should be used. So in a very overarching summary, for uncomplicated non-purulent cellulitis, empiric therapy must cover Streptococcus species. If there is no purulence, staphylococcal coverage may not be needed. However, in the setting of a traumatic wound or in patients with a history of MRSA or intravenous drug use, MRSA coverage may be considered. Abscesses are focal collections of pus located within the dermis and hypodermis that may have surrounding cellulitis. Methicillin-resistant Staphylococcus aureus is the most common causative pathogen, followed by coagulase-negative staph and beta hemolytic strep. Although MRSA is most common, abscesses in patients who use intravenous drugs are unique, as they may be polymicrobial and contain oral streptococci and anaerobes, because saliva is often used to dissolve drugs in clean needles and syringes. The IDSA strongly recommends incision and drainage for treatment of abscesses. Following incision and drainage, whether or not adjunct antibiotics are needed for uncomplicated cutaneous abscesses has been a long-standing debate. The most recent IDSA guidelines recommend that antibiotics be reserved for large or complicated abscesses, defined as those with fever or other signs of systemic infection, an area of surrounding cellulitis greater than 5 centimeters, or occurring in an immunocompromised host. If antibiotics are prescribed, clindamycin or trimethoprim sulfamethoxazole may be utilized, and selection of either agent should be done based on local susceptibility patterns and patient-specific factors. Now moving on to necrotizing skin and soft tissue infections, which result in rapid bacterial spread and necrosis of subcutaneous fat, muscle, and fascia, and they require prompt surgical consultation. Now there are two types of necrotizing skin and soft tissue infections, type 1 being polymicrobial with mixed aerobic and anaerobic microbes, and type 2, which is a monomicrobial with group A strep being most common. Now, you cannot differentiate the two based on presentation alone, so their empiric antibiotic therapy is the same. Empiric antibiotic treatment should be broad, with recommended antibiotic regimens being the combination of vancomycin plus piperacillin-tazobactam plus clindamycin, or linezolid plus piperacillin-tazobactam. Now, in patients with a penicillin allergy, the recommendation is vancomycin plus cefepime plus metronidazole plus clindamycin. Now, you'll see that clindamycin is present in many of these regimens as it has shown to reduce exotoxin production in Clostridial and gas disease and downregulates the host cytokine response. You will notice that when linezolid is utilized, it replaces both the vancomycin and clindamycin in the regimen, as it provides both MRSA coverage and inhibition of exotoxin production. Back to our patient who has now received the 2 4 milligram doses of buprenorphine. His respiratory rate has decreased and he feels less anxious, but his temperature remains elevated. His laboratories have now resulted and are notable for a low potassium, magnesium, and phosphate, as well as an elevated white blood cell count and lactate. Based on this, the team is concerned for a systemic infection, with a likely source being the abscess with surrounding cellulitis on his right arm, which the patient does state has been worsening over the last 4 to 5 days. So this brings us to our 5th assessment question. What is the most likely pathogen causing the infection? Is it A, Streptococcus pyogenes, B, methicillin susceptible Staphylococcus aureus, C, group A streptococci, or D, methicillin resistant Staphylococcus aureus? The correct answer is D. Methicillin-resistant Staphylococcus aureus is most likely as the patient has an abscess and uses intravenous drugs. Question 6. The team performs an incision and drainage as recommended by the IDSA of the abscess and asks which antibiotics you would recommend. Now, the team has decided to add antimicrobial therapy as the patient is exhibiting systemic signs of infection. Would you recommend A, clindamycin 900 milligrams intravenous, B, ceftriaxone 2 grams intravenous plus clindamycin 900 milligrams intravenous, C, cefazolin 2 grams intravenous, or a loading dose of vancomycin 20 milligrams per kilogram intravenous? The correct answer is D, a loading dose of vancomycin, with this load being 20 milligrams per kilogram in a younger gentleman with good renal function. The question prompt indicates that the team is worried about a systemic infection originating from the abscess. This would categorize the infection as severe, for which of the available answers, vancomycin would be the most appropriate. Clindamycin can be used for MRSA coverage, however, due to its increased rates of MRSA resistance and side effects, it is not the optimal choice. Question 7. The team is concerned that the patient might leave against medical advice and would like to have an oral antibiotic regimen available if he leaves. What would the best oral agent be? Would it be A, clindamycin 900 milligrams every 8 hours, linezolid 600 milligrams every 12 hours, C, trimethoprim sulfamethoxazole double strength 2 tablets every 12 hours, or D, cephalexin 500 milligrams every 6 hours? The correct answer is C, trimethoprim sulfamethoxazole double strength tabs, 2 tabs every 12 hours. Trimethoprim sulfamethoxazole is the best answer as it has good MRSA coverage and is the recommended oral agent. Clindamycin has the MRSA coverage but is second line due to, again, the increased rates of resistance and side effects. Additionally, the dose of clindamycin is too high. Linezolid also has MRSA coverage, however, this medication is often expensive, and we were not provided information that the patient has any history of drug resistance requiring alternate therapy. This brings us to our 5th segment, where we will discuss pain management strategies in patients on medications for opioid use disorder, namely methadone or buprenorphine. Pain and addiction are common comorbidities, as chronic pain plays a substantial role in illicit opioid use, and those with addiction often suffer from acute pain conditions. However, managing acute pain in patients with or a history of addiction is complex, as there may be a fear of precipitating opioid withdrawal, triggering a relapse, and/or worsening an addiction. Furthermore, patients receiving medications for opioid use disorder have several reasons to require higher and more frequent dosing of analgesics, as chronic exposure to methadone or buprenorphine may result in analgesic tolerance and cross-tolerance to other opioids, and may produce opioid-induced hyperalgesia, both of which diminish analgesic efficacy. The overarching pain management principles that we will discuss are to continue methadone or buprenorphine, if possible, to avoid an opioid deficit, as patients who are physically dependent on buprenorphine or methadone must be maintained on the same analgesic daily equivalent before any analgesic effect is provided with supplemental opioids. Furthermore, continuing these agents mitigate risk of withdrawal or relapse during or following hospitalization. As stated, patients may need higher doses of pain medications than patients without opioid use disorder. If the patient is on buprenorphine, you will need to overcome the partial receptor agonism, which is possible with higher and more frequent dosing of full mu agonists. Typical pain management guidelines based on etiology of pain should be followed with an emphasis on non-pharmacologic strategies and multimodal analgesia. The primary concern that I have come across in practice when discussing continuation of buprenorphine is that with its high receptor binding affinity, that its partial agonism cannot be overcome. However, this is not the case. Adequate analgesia from full opioid receptor agonists can be attained, but higher or more frequent opioid dosing may be necessary. Now, there are several reasons to continue at least a low dose of buprenorphine throughout the acute pain phase, as it eliminates the opioid washout period where the patient is at risk for relapse. It is also very important to mention that if buprenorphine is held, you must ensure the patient is in mild opioid withdrawal prior to reintroduction. With these options, it is very important that the points are discussed with the patient to allow for shared decision making. Similar to buprenorphine, it is optimal to continue the current dose of methadone to avoid an opioid deficit. Unlike buprenorphine, methadone cannot be found in pharmacy dispensing reports or the prescription drug monitoring programs, so it is imperative to contact the patient's methadone clinic during hours of operation to confirm dosing and date of last dose. Because patients on methadone are chronically exposed to a full mu opioid receptor agonist, they are considered opioid tolerant. However, the side effects of opioid agonism are additive, and toxicity should be closely monitored for and shorter-acting opioids utilized. As partial and full mu opioid receptor agonists, buprenorphine and methadone are analgesic agents themselves. Although these agents can suppress opioid withdrawal for 12 to 48 hours, allowing for once or twice daily maintenance dosing, their analgesic duration is much shorter, between 6 to 8 hours. Therefore, while managing acute pain, the current recommendation is to divide the daily dose and administer it every 6 to 8 hours to provide for more steady analgesic coverage. If the patient experiences pain relief with the divided doses, this does suggest to you that the pain is opioid responsive pain. Alternatively, the daily maintenance dose may be continued at the 12 to 24-hour intervals with addiction, with a short-acting opioid agent titrated to effect. In both dosing strategies, if additional opioid supplementation is needed, the opioid should be a potent full mu receptor agonist like morphine, fentanyl, hydromorphone, and possibly oxycodone. Lastly, just so there is no confusion, any provider can write for methadone or buprenorphine in the emergency department or inpatient setting, as long as that is not their sole purpose for emergency department presentation. Analgesics are used to treat pain, but we know that there are different pathophysiologies of pain, and so utilizing multimodal therapy can target several different pathways. Multimodal pain management should be utilized for most pain conditions in place of monotherapy with opioids, with the use of non-steroidal anti-inflammatories, acetaminophen, gabapentinoids, NMDA antagonists, and sodium channel blocking agents. These can be as effective as opioids for the relief of pain when used in combination. Additionally, as several medications are being dosed at different intervals throughout the day, multimodal therapy also decreases periods of inadequate pain relief that may be present with monotherapy. Acetaminophen has antipyretic and analgesic effects, but lacks peripheral anti-inflammatory properties. The antipyretic and a portion of the analgesic effects result from selective inhibition of cyclooxygenase. Acetaminophen is effective for treatment of musculoskeletal pain, renal colic, radicular back pain, and migraine, and it should be scheduled around the clock for sustained pain relief. It can be given orally, per rectum, and intravenously. And of course, I have to mention that the intravenous preparation does lack data to suggest superior clinical efficacy. And although the use of combination products are typically not recommended, the combination of acetaminophen with ibuprofen has been found to be superior to using either agent alone. The combination using both acetaminophen and ibuprofen was as efficacious as the opioid-containing combinations oxycodone, hydrocodone, codeine plus Tylenol when used for musculoskeletal pain in the emergency setting, reinforcing its use over opioids in mild and moderate pain settings. Daily doses of acetaminophen should not exceed 4,000 milligrams or 3,000 milligrams in patients with a history of liver disease or in the elderly. Nonsteroidal anti-inflammatory drugs reduce the levels of prostaglandins in the central and peripheral nervous system, relieving pain, swelling, and redness. They are effective for musculoskeletal pain, renal colic, and back pain. Traditional NSAIDs block prostaglandin synthesis via non-selective inhibition of COX-1 and COX-2 isoenzymes. These agents include aspirin, ibuprofen, naproxen, and ketorolac. As COX-1 is responsible for maintaining gastrointestinal mucosa, regulating renal blood flow, and platelet aggregation, side effects of the non-selective NSAIDs include nausea and vomiting, gastric ulceration, bleeding, and kidney injury. There are a few agents that are non-selective but have a higher affinity for the COX-2 enzyme, and these include indomethacin, meloxicam, and diclofenac. This selectivity results in an improved gastric safety profile. However, COX-2 selectivity has shown to increase risk of myocardial infarction, stroke, and heart failure, resulting from induction of the thromboembolic state. Celecoxib is the only COX-2 selective NSAID currently available on the market, as other agents have been removed due to their increased cardiovascular risk. When selecting an NSAID, one must weigh the GI, renal, and cardiovascular risks. If the patient is at higher risk of a GI bleed, consider adding a proton pump inhibitor to reduce the risk of bleed. All NSAIDs have an analgesic ceiling dose, which is lower than the anti-inflammatory maximal dose. When the ceiling dose is met, additional increases in dose provide no further analgesic benefit. The ceiling dose has been reported as 400 milligrams for ibuprofen and 10 milligrams for intravenous ketorolac. With this in mind, lower dosages should be selective for non-anti-inflammatory pain, and higher ranges are reserved for those situations in which inflammation and swelling are significant contributors to the pain. Ketamine is an analgesic often used for pain management in the setting of intractable pain, neuropathic pain, or in patients with opioid tolerance and opioid-induced hyperalgesia. Once in the bloodstream, ketamine distributes to the central nervous system in about 30 to 45 seconds, resulting in a very rapid onset of action. When using ketamine for pain, a sub-dissociative dose of 0.1 to 0.3 milligrams per kilogram intravenous as a single dose, or 1 to 5 micrograms per kilogram per hour as a continuous infusion, or 0.7 to 1 milligram per kilogram intranasally should be employed. Ketamine is highly water-soluble with high lipophilicity and should be dosed based on ideal body weight. Ketamine's adverse effects are dose-dependent. At sub-dissociative doses, ketamine may result in psychoperceptual side effects, such as a feeling of unreality, sedation, nausea, vomiting, dizziness, and nystagmus. These adverse effects have been shown to be decreased when administered as an infusion over 10 to 15 minutes rather than a bolus dose. Lidocaine functions as an analgesic through sodium channel blockade that lessens the influx of calcium ions into the nerve terminals, whereby reducing spontaneous nerve firing and the sensation of pain. Lidocaine has an analgesic, anti-hyperalgesic, and anti-inflammatory effects. Historically, lidocaine has been utilized for the treatment of chronic neuropathic pain, but more recently, lidocaine has been studied in renal colic, headache, and in the perioperative setting. Intravenous lidocaine can be given as a bolus of 1 to 2 milligrams per kilogram with a maximum of 200 milligrams, or as a continuous infusion of 0.5 to 3 milligrams per kilogram per hour based on ideal body weight. Administering the bolus dose prior to initiating the continuous infusion may result in faster time to therapeutic effect. Now keep in mind that lidocaine is a von Willems class 1B antiarrhythmic, and there is the potential of developing cardiac arrhythmias. Although the risk is low, it does increase with higher dosages and accumulation in the setting of liver dysfunction. However, more common adverse effects include dizziness and paresthesias. Gabapentinoids bind presynaptic voltage-dependent calcium channels and reduce the flow of calcium ions into the nerve terminals and reduce nerve firing. So contrary to popular belief, these agents do not interact with the GABA receptor. Gabapentin and pregabalin are effective treatments for post-herpetic neuralgia, phantom limb pain, peripheral neuropathy, and pain caused by nerve compression. Although gabapentin and pregabalin have the same pharmacologic profile, the binding affinity for and potency of pregabalin is 6 times greater than that of gabapentin. Gabapentin also has variable inter-individual bioavailability with satural oral absorption. Now this means that its bioavailability actually decreases as the dose increases. Therefore, smaller doses given more frequently may be required to optimize gabapentin's absorption. In comparison, pregabalin has a more predictable linear pharmacokinetic profile that is not saturable. Now I do want to highlight that although gabapentin and pregabalin may be initiated in the emergency department, their onset of pain relief typically isn't seen immediately, and these agents require slow titration to effect over several weeks. Transdermal preparations are attractive options to reduce systemic absorption and adverse effects. The slide lists the most commonly used topical agents and their associated formulations. This table is for your reference that summarizes the different pain conditions we discussed in the non-opioid agents that have been found efficacious. So in summary, buprenorphine or methadone should be continued during inpatient hospitalization to help manage acute pain and mitigate risk of withdrawal or relapse. Use of non-opioid scheduled analgesics provides sustained analgesia in an opioid-sparing effect. Patients with opioid overdose, opioid use disorder, or withdrawal should participate in shared decision-making about their pain management strategies. And if supplementation with full mu opioid agonist therapy is needed, using higher and or more frequent dosing of short-acting agents is needed. Back to our patient case. Following the incision and drainage, our patient is endorsing significant pain at the incision site. On a scale of 0 to 10, the patient states that the pain is a 7 and is not relieved with repositioning. HL received 2 4 milligram doses of buprenorphine previously. The team is wondering if the buprenorphine will help his pain or if they should discontinue it and switch to a different opioid. What would you recommend? A. Continue the buprenorphine at 12-hour dosing interval. B. Do not give additional buprenorphine because it is ineffective as an analgesic. C. Continue buprenorphine at 6-hour dosing intervals. Or D. Continue buprenorphine but only dose once daily. The correct answer is C. Continue buprenorphine at 6-hour interval. Buprenorphine has analgesic properties as a partial opioid receptor agonist, but again, these effects only last 6 to 8 hours, so it is best to divide the dose every 6 hours. The next question. The team agrees with your buprenorphine recommendation and now would like to add a non-opioid pain medication as the patient's pain is quite significant. What would you recommend? A. Ketamine 15 milligrams intravenous, gabapentin 300 milligrams oral, C. Ketorolac 30 milligrams intravenous, or D. Lidocaine 20 milligrams intravenous. The correct answer is A, ketamine 15 milligrams intravenously. Ketamine is appropriate as the patient is having moderate to severe pain, which will likely not be relieved by a ketorolac alone. Additionally, the ketorolac dosing of 30 milligrams intravenous is higher than the analgesic ceiling of 10 to 15 milligrams. Gabapentin and lidocaine are best for treating neuropathic pain for which the patient does not have, and they do have slow onsets of action. Moving on to our last segment, segment 6, discussing alcohol withdrawal syndrome, which, as you can see from the statistic on the slide, is a common condition encountered in the emergency department, inpatient, and ambulatory settings. The ingestion of alcohol impacts many functions throughout the body. However, in relation to the development of alcohol withdrawal is the effect of its binding to the GABA-A receptor. At low levels and frequency of ingestion, we see the predictable GABA effects of decreased anxiety, decreased inhibition, and altered motor sensors. However, if alcohol is consumed in higher quantities for an extended period of time, we see upregulation of NMDA receptors and a downregulation of GABA-A receptors. In our chronic or regular alcohol user, compensatory adaptation occurs when GABA-mediated inhibition is decreased and glutamate-mediated excitation is increased, which when intoxicated, this hyperactive state is kept in check by the depressive effects of alcohol. However, when the individual stops drinking, glutamate-driven excitation is unmasked and alcohol withdrawal symptoms are experienced. These can present as both autonomic and neuropsychiatric dysregulation, with anxiety, sweating, tremors, and headache, with more severe consequences being seizure, delirium, and death. There are validated predictors to help us identify patients who are at risk of a more severe alcohol withdrawal course. These include a history of severe withdrawal, history of a mood disorder, onset of withdrawal in the presence of high blood alcohol levels, electrolyte derangements, and indicators of liver injury. The Clinical Institute Withdrawal Assessment for Alcohol, or more affectionately known as the CWA scale, is the most widely used symptom monitoring instrument for alcohol withdrawal. Following CWA scoring, patients are categorized into mild, moderate, and severe withdrawal based on the score. Although widely used, there is increasing criticism for CWA scoring as it is rather subjective and scores can be influenced by conditions other than alcohol withdrawal. Back in the day, the CWA scoring system was built for the ambulatory setting where patients are able to answer questions in a credible way. Therefore, some institutions are moving to a more objective RAS scoring where you simply visualize how sedated or agitated a patient is. I want to preface my pharmacotherapy discussion with stating that the medications I'm discussing are to treat patients in moderate to severe withdrawal, and I will not be discussing medications such as carbamazepine, valproic acid, or gabapentin that can be used for withdrawal prevention or treatment of mild to moderate withdrawal. All medications used to treat the underlying pathophysiology of alcohol withdrawal work on the GABAergic system. Benzodiazepines are the backbone and medication of choice for most forms of alcohol withdrawal because they have the most empirical evidence of efficacy and safety in reducing signs and symptoms of withdrawal and incidence of seizures. They are agonists of the GABA-A receptor and work by increasing frequency of channel opening. Longer-acting benzodiazepines like cordiazepoxide and diazepam are preferred as they offer a smoother detoxification. The potential side effects are sedation, respiratory depression, and delirium. Lorazepam, diazepam, and chlordiazepoxide are the most common benzodiazepines used to treat alcohol withdrawal. While no particular benzodiazepine is more effective than one another, longer-acting benzodiazepines like diazepam and chlordiazepoxide are the preferred agents due to the clinical benefits of their longer duration of action and ability to self-taper. However, lorazepam does have a longer intracerebral half-life that has been reported up to 12 hours, compared to 15 to 30 minutes with diazepam. This allows for a longer-lasting anti-epileptic effect. So if you have a patient who has seized or has a history of seizures, I would recommend considering lorazepam. Lorazepam and diazepam can be given intravenously or intramuscularly, along with orally. Diazepam also has a rectal option diastat. And I will say, if you've never looked at the Diastat product, I urge you to take some time to review how to adjust the dosing on the product. As from personal experience, this is not something that you want to figure out in an emergency with all eyes on you. If the patient is in mild or possibly moderate withdrawal and you're able to give the benzodiazepine orally, this really is preferred because it has a slower rate of accumulation in the brain that reduces the risk of tachyphylaxis or tolerance to the benzodiazepine. So if you can wait the 30 to 60 minutes for onset of the oral agent, I would recommend that. Benzodiazepines can be given in either a fixed dose or symptom-triggered approach. In the fixed dose approach, a predetermined dose is administered at a fixed interval, with doses decreasing in a gradual taper over several days. When using the fixed dose schedule, patients' signs and symptoms should still be monitored, and allowances should be made to provide additional medication if needed. A fixed dose approach may be beneficial if short-acting benzodiazepines are used to avoid breakthrough withdrawal. On the other hand, symptom-triggered benzodiazepine dosing is the recommended approach, and as the name suggests, medication is only given when the alcohol withdrawal symptoms indicate need for dosing. Symptom-triggered therapy is as effective as fixed dose, and it causes less sedation, it requires less medication, and provides more rapid detoxification. Providers may also choose a front-loading approach where moderate to high doses of long-acting benzodiazepines are given frequently at the onset of treatment to achieve rapid control of withdrawal. A front-loading regimen is recommended for patients at high risk of severe withdrawal. Resistant alcohol withdrawal is a form of continued severe or complicated withdrawal despite having received high doses of benzodiazepines. There is no true agreement regarding the precise amount of benzodiazepines required before considering a patient to be in resistant withdrawal, but various studies have used the cutoff of greater than 10 milligrams lorazepam or 50 milligrams diazepam within the first hour of treatment, or greater than 40 milligrams of lorazepam or 200 milligrams of diazepam in the first 3 hours of treatment. There are a few theories as to why some patients experience resistant withdrawal. The first is that benzodiazepines' pharmacologic effect depends on the presence of endogenous presynaptic GABA molecules, because benzodiazepines do not independently open the GABA channel. However, patients with chronic alcohol use disorder have less endogenous GABA. The second reason is that with chronic alcohol use, there is actually a conformational change to the GABA receptor, making it harder for GABA to bind. And the third is that benzodiazepines only work on GABA receptors, which is only part of the neurobiology of alcohol withdrawal. Remember that we also have an upregulation of glutamate-mediated excitation. With frequent and high levels of alcohol consumption, the glutamate receptors actually multiply, so that when drinking you have a less mental status depression. But when you stop drinking, you have uncontrolled excitation of this pathway. Phenobarbital has a dual mechanism for the treatment of alcohol withdrawal and works on both GABA and glutamate signaling. With that said, at conventional doses, phenobarbital does not have as much glutamate receptor inhibition as other barbiturates like pentobarbital. Even though one would imagine that phenobarbital may be superior for alcohol withdrawal treatment due to its dual mechanism, supportive literature is lacking for phenobarbital monotherapy or its superiority over benzodiazepines. And most studies do utilize phenobarbital as an adjunct to benzodiazepines. Which this is not surprising, as benzodiazepines and barbiturates have different binding on and activity at the GABA receptor, and so their activity and depressant effects are synergistic. I do want to highlight that if phenobarbital is used as monotherapy and the patient experiences a seizure, then a fast-acting benzodiazepine should be administered. There are a few dosing strategies that have been reported. The first strategy is providing bolus doses of 260 milligrams intravenous, followed by 130 milligrams intravenous as needed. This strategy is preferred if large doses of benzodiazepines were previously given or if the patient is already somnolent. The second dosing strategy is providing a larger loading dose up front of 10 milligrams per kilogram intravenous run over 30 minutes to avoid hypotension. Upon reassessment, if the patient requires further treatment, an additional 260 milligram or 130 milligram intravenous bolus may be given. Phenobarbital has a more narrow therapeutic window compared to benzodiazepines. However, there is a linear relationship between dose and drug level, resulting in predictable plasma concentrations with a goal of 10 to 15 micrograms per milliliter. This predictable linear relationship allows weight-based doses to reproducibly achieve therapeutic drug levels. During treatment, there is no need to check drug levels, as dosing should be based on symptom control. However, if toxicity is a concern, plasma levels are easy to obtain. Phenobarbital also has a long half-life, allowing for a gradual tapering that may last longer in liver dysfunction. As I stated, there is a lack of quality studies detailing the benefit of phenobarbital compared to benzodiazepines. However, a few retrospective chart reviews have indicated that phenobarbital use may lead to less delirium, paradoxical reactions, mechanical ventilation, and ICU admissions. It also may be superior at treating severe withdrawal. Ketamine can be used as an adjunct agent to benzodiazepines, as it hits the other limb of the pathophysiology as an NMDA receptor antagonist. Data on safety and efficacy is currently limited, but perceived advantages are reducing benzodiazepine requirements and efficacy in those with benzodiazepine-resistant withdrawal. Dexmedetomidine is a centrally acting alpha-2 agonist that reduces sympathetic output. In the setting of alcohol withdrawal, this can decrease the overactivity of the excitatory molecule glutamate and help normalize vital signs, but it will not agonize the GABA receptor and treat the underlying condition. Dexmedetomidine does target a different pathway than benzodiazepines and phenobarbital, so its effects are additive, and because it provides light sedation, it does not lead to respiratory depression. However, because of its anti-adrenergic effects, hypotension and bradycardia may occur, so a slow titration is recommended. Propofol potentiates GABA and antagonizes NMDA. It has a rapid onset and is fairly easy to titrate. However, patients generally need to be intubated, which limits its use. Like dexmedetomidine, clonidine can be used to help control autonomic hyperactivity and anxiety when symptoms are not controlled by benzodiazepines or phenobarbital. As with dexmedetomidine, clonidine should not be used alone to prevent or treat alcohol withdrawal. Patients with alcohol use disorder often have poor nutritional status and require supplementation. Thiamine, folate, and multivitamin supplementation should be initiated in patients with significant alcohol use. Intravenous or intramuscular administration of thiamine is preferred in the acute setting, as oral thiamine is not well absorbed. Typical dosing is 100 milligrams intravenous or intramuscular per day, or 500 milligrams intravenous or intramuscular every 8 hours if concerned for Wernicke's encephalopathy. Folate can be given orally, intravenously, or intramuscularly, and a multivitamin should be started once the patient is able to take oral medications. Other electrolytes such as sodium, potassium, magnesium, and phosphate should be checked and repleted as needed with intravenous therapy. Back to our patient case. HL has now been in the emergency department for about 6 hours. He has received his 2 doses of buprenorphine for opioid withdrawal with good effect, and his pain is now at a 3 out of 10 following the intravenous ketamine administration. However, the team notices that he's becoming more tachycardic, altered, and tremulous. Upon examination, HL has tongue fasciculations. The team asked the nurse to perform an alcohol withdrawal assessment for the patient and provide a numerical CWAS score. Following nursing assessment, HL is given a CWAS score of 16. Based on the nurse's CWAS assessment, how severe is HL's alcohol withdrawal? Is it A, he is not in alcohol withdrawal, B, mild, C, moderate withdrawal, or D, severe alcohol withdrawal? The correct answer is C. A CWAS score of 16 indicates moderate alcohol withdrawal. The team would like to treat the patient now for his alcohol withdrawal and ask you what initial therapy to begin. What would you recommend? A, lorazepam, 4 milligrams intravenous, scheduled every 2 hours. B, lorazepam, 2 to 4 milligrams intravenous as needed based on your CWAS score. chlordiazepoxide 100 milligrams oral scheduled every 6 hours, or diazepam at 20 milligrams intramuscular as needed based on your CWA score. The correct answer is B, lorazepam at 2 to 4 milligrams intravenous as needed based on the CWA score. Studies have shown, as I stated, that symptom-triggered benzodiazepine dosing based on CWA scoring is optimal as it results in less drug being administered and a faster recovery. Chlordiazepoxide is a reasonable option. However, the patient is tipping towards more severe withdrawal, so waiting the 30 minutes for onset may not be appropriate in this case. Diazepam can be used instead of lorazepam. However, answer D provides a flat dose and intramuscular administration, which is suboptimal based on erratic absorption. Moving on to question 12. The patient has required 18 milligrams of lorazepam in the first hour and is becoming more altered. What would you recommend for treatment entering the second hour? A, stop the lorazepam and start 10 milligrams of IV diazepam scheduled every 2 hours. B, stop the lorazepam and give phenobarbital 260 milligram intravenous bolus. C, stop the lorazepam and give phenobarbital loading dose of 10 milligrams per kilogram intravenous run over 30 minutes. Or D, continue the lorazepam but switch to scheduled dosing of 4 milligrams every hour. The correct answer is B, stop the lorazepam and give phenobarbital 260 milligrams intravenously. The patient appears to be in benzodiazepine refractory withdrawal, so switching to phenobarbital is the most appropriate action. Answer B is best as the patient has already received a large dose of lorazepam, so giving a smaller phenobarbital bolus as compared to the 10 milligram per kilogram intravenous load is the safest option to decrease risk of unwanted CNS depression. That concludes the different segments in this module. The key takeaways are: number 1, medication selection for acute agitation should be guided by the most likely cause of agitation, which is often challenging, with special attention to time of therapeutic onset. Key takeaway number 2, buprenorphine can be utilized to ameliorate naloxone-induced opioid withdrawal and should be continued in the emergency department to help mitigate the risk of withdrawal and relapse in patients with opioid use disorder, opioid overdose, or withdrawal. And key takeaway number 3, in patients with benzodiazepine refractory alcohol withdrawal syndrome, phenobarbital should be utilized with its additional glutamate receptor inhibition. That concludes this presentation, and I thank you all for participating.